The COMBI-AD trial was an adjuvant trial, phase 3 adjuvant trial with the brafenib trametinib versus placebo, which gave and which showed interesting results. If you look at the relapse-free survival curves, it's really amazing. An hazard ratio of 0.47. That is to say, 53% of risk reduction for progression. So, and also, if you look to these curves, there is an early separation. So this means that there is an early impact of the treatment on this kind of patients with lymph node metastasis. And this impact, it's evident in all the subgroups, so the patients with stage 3A, 3B, and 3C with a similar hazard ratio. It is also interesting to see that this benefit was maintained also in terms of overall survival, looking to the 78% of patients still alive at 3 here with another hazard ratio of 0.53, that is to say 47% of risk reduction for that. So why may be possible this? Because it was not so obvious, because we are talking about the adjuvant setting of patients that is different from the advanced disease. Because in the adjuvant setting we have a minimal residual disease, and sometimes the cells, the cluster of metastatic cells are dormant. So in this condition it's difficult for treatment-like target therapy to inhibit the growing of this kind of cell. But now we know that this works. It probably works for an immunological mediated mechanism of action, because we know that BRAF plus MEK inhibitor can increase the infiltrating tumor, can also upregulate the tumor-associated antigen, the surface of the melanoma cell, can reduce the Treg, can also upregulate the MHC that is important from the adaptive immunotherapy. So also in the patients with a minimal residual disease, it's like patients in complete response, we know that in these patients we have a baseline immune-related gene signature that of course can help in reaching the complete response. And these are the patients still with low tumor burden and with normal LDH. So in the adjuvant setting probably we have the good condition for acting in an immunological manner. This may be responsible for the long-term benefit. So what is changing now in the managing of our patients? Now we have an effective treatment also in this kind of patients, and for sure these patients will be treated with these compounds. We'll see in the future if really we can have a long-term benefit with target therapy, even these patients. But of course the good news for the patients, and that probably now we can treat these patients earlier in order to prevent the metastatic disease.